Good afternoon, everyone, and welcome to our second webinar in the series. I'm Charlotte Stevenson. I'm one of the business development managers at Cardiff University, and it's my role to facilitate the fantastic academic team in this type of CPD activity. A few bits of housekeeping before we get going today. We've got the chat function open. It's completely anonymous, so if you want to contact the team or you've got any questions about the content, pop it in the chat and we'll have time at the end for the team to answer any questions you've got. We're all working in different locations, so bear with us if there's any technical problems or anything like that. We've got the evaluation, which I will send around to you at the end, and will be there's a QR code at the end of Joe's presentation. Please, if you could fill that in, that would be really helpful in allowing us to do any kind of further activity like this. I'll now hand over to our speaker this afternoon, Dr. Joe Hayes. Joe.
Thank you, Charlotte, and thank you for all of your setup with the webinars and for Cardiff University's support in delivering these free webinars to our community staff, GPs, primary care staff, district nurses, palliative care teams, hospice and social care providers. So thank you, and thank you to the rest of the team on that slide who helped to put together all of these webinars. So this is the second one, and we hope that you'll join us for the ones in subsequent weeks. I'm going to talk today about the deteriorating patient, deteriorating palliative care or frail patient, I guess, some reversible causes and some not so reversible causes, and challenges, let's call it, rather than challenging behaviour. So challenges for us all. I'm really keen to, it's tricky on a big Zoom call, but I'd be really keen to try to make it a little bit interactive. So I've done some polls. There's not necessarily a right answer on the polls, and I've asked people to give their opinions in the chat. So it'd be really great if we could have just a little bit of interaction going on. And my colleagues who are out there, perhaps Emily, James and Elaine, if you could just monitor the chat and come in if you think there are questions that it would be best to stop and address as we go, or perhaps store them up at the end, that would be great. And I'm sure Charlotte will keep an eye on things as well. Okay, so my name is Jo Hayes. I'm consultant in palliative medicine based at the Marie Curie Hospice in Penarth, and I work with the community specialist palliative care team covering the Vale of Glamorgan, and I work with all of my colleagues down at the bottom there covered in daffodils from the Marie Curie side, and all of my colleagues from City Hospice there who are the community specialist palliative care team for the city of Cardiff. I work with obviously many more people other than my immediate teams, and in looking after our palliative care patients, mainly in the community for our teams, we're working all the time with GPs, district nurses, hospice at home and social care and nursing home staff, community pharmacy, out of hours GP service and the ambulance service. So it'd be really great if you could just let me know who we've got on the call and what your work setting is, and then I can see who I've forgotten of those groups. So it'd be really great if you could just tell us who you are. Thank you. Great, so we've got most people, almost 90% of people who've participated there. And 30-odd% GPs or GP trainers, a good number of district nurses there, and some people from the palliative care team and nurses from elsewhere, and we have not able to specify further. And we've got a few nursing and residential home staff there, which is great. Thank you. And could you just run the next poll, please, Charlotte? That's about setting, I think, where people are working. Be really great if everyone could just fill that in about your work setting. I know lots of you will work in both. Pick one, or many, more than one. Thank you. And we've got almost 90% of respondents there who are mainly community, which is great because that's where we have targeted these webinars. And again, a reasonable number of people who are working in nursing homes, which is great. Okay, thanks, Charlotte. All right. So I hope to cover an approach to deteriorating palliative care patients, some potentially reversible causes and some challenges, as I said. Put your questions on the chat function. And when we run the polls later, there is sort of, I don't agree with any of the options, or I can't decide, or I'm not sure other, please put stuff in the chat and we'll try and pick up some of your questions or queries or comments as we go. Thank you. Okay, so I'm just going to give everyone a minute or two to read this slide. So I've just based some of this stuff on patients that I have met over the years. None of them are the true story of a real patient, and obviously none of the names are real, but most are an amalgamation of patients that I have come across or been involved with in many years of doing palliative care and working in the community. So Ivy's in her 80s, heart failure, kidney disease, dementia, so lots of comorbidities, multiple previous strokes. She lives in a nursing home and feeding at risk, meaning that she would be at risk of episodes of aspiration, and perhaps has her swallowing isn't 100%, and decisions have perhaps been made not to do things like feed her in an alternative way or make her nil by mouth. And the nursing home and staff who are looking after her would have a sort of guidance about how to manage that and how to help her as best they could. So functions deteriorated over the last couple of years, and she's not as mobile as she was. She needs more help to transfer, or may need equipment like steadies and that sort of thing in order to get about. She's also had several recent hospital admissions with things like UTIs, confusion, query cause, chest infections, or possible aspiration. And like lots of elderly patients like her with comorbidities, when she's been discharged from hospital or had an episode where she's been more unwell, she has recovered, but not quite back to where she was, and there's perhaps been a stepwise deterioration in her general condition. She appears happy in her nursing home. She's got lots of family who visit regularly and loves seeing her grandchildren. Her husband's very caring and says that she gets very upset and aggressive in hospital, and she doesn't know where she is, and it's overall not a great experience for her generally. So that's Ivy. Okay. So you will work in lots of different settings. You may be one of the staff in the nursing home where she lives, or you may be a GP or a GP registrar, or you may be a district nurse, and lots of nursing homes have input from district nursing, I know, or you may be one of our specialist palliative care teams. But let's imagine you're called from the nursing home to say that Ivy is breathless, confused, agitated, and has a high temperature, and the care home staff wish some advice and help in how to manage that. So I'm just going to get your immediate thoughts, if that's okay. Could you put our next poll up, Charlotte, please? So we're assuming that you have got responsibility for some kind of assessment of this lady. Yeah, how would you assess her? Thank you. So lots of people opting for face-to-face assessment. Some people asking palliative care or district nursing to assess, and then a few people wanting to do telephone or video consultations. And I realise from the general practice side that might well be your first port of call to assess via telephone and then decide. And it's possible that it might move on to face-to-face. I also realise that not everybody can be assessed face-to-face, and it is difficult to fit everything into all of our days. But I would suggest this is potentially a bit of a tricky situation where we might need to have conversations about what she might want, what her family might want, what we think is the appropriate clinical thing to do. And I think face-to-face is probably our ideal assessment if it were a perfect world where we all had the time and the means. anybody wants to make any comments, pop them in the chat for me and we can try and pick them up as we go. Okay, will you just run the next poll, Charlotte, if that's okay? So what are we going to do? What shall we do for Ivy, who's, you've got her history, she's breathless, confused and agitated. Okay, and she feeds at risk, remember? I'm kind of hoping people are thinking, well, not necessarily just one of those options, maybe lots of them, maybe not, depends on this, depends on that, depends on what I find. Okay, thank you. So we've got probably about more than half people there that would consider starting antibiotics. I suppose I have described something that could well be a chest infection, might be to do with aspiration, could be COVID. Yeah, so antibiotics might be a consideration. There's somebody there suggesting to admit her either to hospital or a hospice in order to be assessed. And people have suggested that they've put stuff in the chat. So does anybody want to tell me what's in the chat? And don't want to put people on the spot necessarily, but my panelist colleagues on the call, does anybody want to make any comments on our situation here?
I think in the chat, there's mention about exploring her wishes around, does she actually want treatment of reversible causes, where a preferred place of care and death are, and ceilings of treatment. And then someone else has mentioned actually maybe to see whether we can confirm whether there's whether oral antibiotics are actually warranted. But I think the main focus there is on actually clarifying the advanced care planning, which I think for me is where what I would have been going for was actually other, and actually saying, well, okay, just because there may be something reversible, does she want us to reverse it? Do the family get an idea of what conversations have been had or what's been written down, and whether she would want that reversed if she's if either for symptomatic benefit or actually to try and prolong her life for a period. So I think, yeah, that seems to be what's come under other.
James, and deliberately no really definite right answers in those options there. Although I think we would probably have to just consider whether sending her to hospital is the right thing to do and take all of those things into account. And we may well be the right thing to do, but we do need to consider all of the things that you've mentioned. Okay, thank you. I'm just going to talk around this a little bit more. So this is a slide that my colleague Margaret Capel, for those of you who were on the call last week, showed, and it's about identifying those people that perhaps would need advanced care planning, that we should be talking about their future wishes and needs and wants. So would you be surprised if this patient died? And I've got lots of stuff, so I can't see there, within the next 6 months, and sometimes these tools are for the next 12 months, aren't they? If you're not quite sure about that, then look at her general indicators. So performance status poor, limited self-care in bed over 50% of the day, and that might well apply to this lady, mightn't it? Not sure about weight loss, 2 or more unplanned admissions in the last 6 months, which would apply to her. Not necessarily a new diagnosis of a specific progressive disease, but she has, if you look below, got lots of multi-morbidities and comorbidities, hasn't she? And she's resident in a nursing care home. And, you know, living in a nursing or residential home doesn't necessarily mean, obviously, that you're in the last year of your life, but the chances of that are much higher because people are living there because they need help and can't necessarily manage at home on their own anymore. So in terms of 2 or more disease-related indicators, she's got lots of comorbidities, but not necessarily one specific disease. We did mention that she had dementia, and there are some indicators there about sort of worsening dementia. So recurrent febrile episodes or infections and aspiration pneumonia is there. So that's one suggestion that she's somebody that we really need to be thinking about advanced care planning, and it's got swallowing difficulties under dementia there as well. Okay, so if your patients fit these criteria, then we should be thinking in terms of advanced care planning for them, reviewing their priorities, their medicines, perhaps putting them on your palliative care registers and talking to their family about the future and what they might want. Okay. This slide was also shown last week and talks about trajectories of how people might deteriorate. So in cancer, patients often have a period of functioning pretty well and then might decline in a reasonably linear way. It's very variable though, and it depends what other illnesses you might have as well as what cancer you've got. The organ failure over there on the left-hand side fits people with things like heart failure or COPD that might decline gradually but have episodes where they really are quite unwell, where they decompensate or have an infective exacerbation, and you're never quite sure which one of these is the one that's potentially going to be the end of their life, and then they might not recover from. This lady Ivy is probably more down here, isn't she, in terms of dementia, frailty and decline. Her function's reasonably low, but if you look at that line, it's quite difficult to predict when she might actually be towards the end of her life in any sort of accurate way, but you can see the trend. So for Ivy, it might help to place her situation in a longer context. We've described her gradually becoming less mobile and less able to do the things that she could do, less able to swallow properly, and becoming distressed and disorientated when she's in a different place. So everything that you've all put on the chat and that James has talked about, we would want to consider ethical principles in what we did next. What do we know about her wishes? I don't know whether she's able to tell us at the moment. Having dementia does not mean that you lack capacity, but it might do. And we've also said that she's now acutely unwell, so she might not be in a good position to tell us right here and now about what she might want, which is why it's important to have these conversations when people are perhaps not acutely unwell and are able to talk to you. Benefits versus risks of any treatment options that you might take. We'll talk about capacity a little bit in a minute, and we've already mentioned advanced care planning. And we're going to talk in more detail about that in a later talk as well. But we'll keep coming back to it, I think, in terms of how to manage people who are deteriorating and what to do next. So quick slide on mental capacity, just to remind us all. So if you lack mental capacity, you would need to have an impairment of your mind or brain, which leads to an inability to make a specific decision when needed. So it's decision specific. In this case, it could be whether she wanted to have antibiotics. It could be whether she wanted to move her place of care to a hospital acutely. And it's about that specific decision. So you wouldn't say that people couldn't make decisions generally. It's sometimes about preferred place of care and where people would like to go on discharge from a hospital, let's say. And it's sometimes about where they would like to have their end of life care. So in order to demonstrate mental capacity, you need to understand the information you're being given, retain that, weigh it up, and be able to communicate your wishes and feelings. And it's our duty as healthcare professionals really to try and help people to make decisions where they can. So you might ask them what's a good time of day for them. You might time it around medicines and things. You might time it for when family are around. You might not do it when they're acutely unwell with a UTI, for example. You would consult with those close to them, so people that know them well, could be family or friends. But the purpose of asking friends and family is so that they can tell you what they know about what this person might have wanted. Unless they're officially a lasting power of attorney, they can't necessarily dictate what happens, but useful to have their opinions. And we always want to work with wider family and friends and to try to come to a sort of consensual decision rather than creating conflict, don't we? If someone lacks capacity, decisions should be made in their best interests. And you're probably familiar, we talk about least restrictive options, so not limiting somebody's options. So if we don't feel that they are able to manage at home, but that's what they have said that they have wanted, but we don't feel they've got capacity for that decision, and we make a best interest decision that they need to be in a different place of care, then it could be that that's temporary while we see how things go over the next few weeks and see if they, occasionally sometimes people would regain their capacity and therefore be able to make different decisions. And if somebody is somewhere where they are communicating that it's not what they wanted or not where they want to be, and they are being prevented from leaving that place, then, or prevented from making decisions that they would want, then their liberty may be deprived. And there's a whole load of, official deprivation of liberty safeguards and procedures that we would have to go through in order to do that. Is Ivy dying? I think she could be, couldn't she? I think is the answer to that. And one of these episodes, she may well be, or she will be at some point. How do we diagnose dying? It can be quite tricky. I've just listed the NICE guidance there. So they've suggested some signs and symptoms for us to decide whether people are dying or not. So mottled skin, Cheyne-Stokes breathing, increasing fatigue, social withdrawal. And some of that might describe me when I've had a bad Friday in work, to be honest, of social withdrawal, and I'm feeling quite tired. And there's not enough evidence to recommend tools which predict prognosis. And I think if someone had mottled skin and Cheyne-Stokes breathing, then would suggest that, someone might be dying within hours or days. And I think we'd all have a reasonable chance of diagnosing dying in that circumstance. I'm not sure that this is particularly helpful. And it's normally about looking at people over a short period of time, really, and seeing how quickly things are changing. So it can be quite tricky when you work in palliative care, that you suddenly sort of parachuted in, you see someone for the first time and everyone's looking at you to say, well, is this it? Is this person towards the end of their life? It's actually quite hard sometimes to diagnose dying, but we need to try our best to do it wherever we can, because otherwise patients, families, and the people trying to look after them are left with more uncertainty than we might want. Okay, so management of general deterioration can be managed in a similar way to any other symptom: pain, shortness of breath, nausea and vomiting. If you can identify a cause, and in Ivy's case it could be that she's got a chest infection, then you can think things through in a more logical way and try to make the best decisions you can. So if you've got a cause, you can investigate and treat reversible causes appropriately. We talked last week about how some of our patients in palliative care, maybe with widespread metastatic disease from cancer and deteriorating function, might develop something that looks like spinal cord compression, but it might not be appropriate to haul that person out of their home or wherever their setting is and do urgent scans and send them off for radiotherapy. That might not be appropriate when you look at their whole situation in context. And then we can treat symptoms if we can't reverse a cause or we don't think it's appropriate to investigate. And we talk about treatment in terms of non-drug and drug treatments. So important when you're dealing with patients, families, and those close to them to explain the situation as you see it. And you might not necessarily have all the answers or be certain. You might be setting out options. In Ivy's case, you might be saying, I think this is another chest infection. I know that, she hasn't liked being in hospital previously and became quite distressed there. And we need to talk about how we manage it on this occasion. I am really concerned that she's quite poorly, and it could be that she doesn't recover from this, and in that case, is sending her to hospital the right thing to do, or can we manage things here, and how can we manage things here, and what should we or shouldn't we do? We've talked a lot about taking into account her wishes, capacity, and involving appropriate others, and about our ACP decisions, but do they apply to the situation that you're in? Lots and lots of people say, I'm not going back to hospital. And often that's appropriate. sometimes you need to go through actually what's happening at the moment and what might the benefits of going to hospital be if you were to choose that. People that say I'm never going to go back to hospital may not have thought what happens if I fall over and break my hip. You know, I think it might be a different situation then. So one approach for Ivy, and I'm not necessarily suggesting this is the only or the best or the right way of doing things. There's no right answers for these scenarios because, you know, they're not real patients that you know and have all of the information and all of the circumstances. But one of the approaches that you could perhaps use are, you know, she's got a high temperature, she's agitated, she might be more comfortable if she was less pyrexial. We could consider whether oral antibiotics are appropriate or realistic, whether she might be able to take them. We could try and push oral fluids a little bit if we felt that she was dry, and we could review the situation soon afterwards and see which way we thought things were going, because she's clearly quite poorly and could be towards the end of her life. So at the same time, we could plan for end of life care. We could be saying to her family and to the staff looking after her, look, she's really quite sick. We'll try and see if she can take some oral antibiotics, and we'll try and keep her fluids up. But I do think we need to make some plans for if she's not getting better. You know, have we got things like medicine, injectable palliative care type medicines that we might need? Have we informed all of her family what we think the situation is? Have we got the right people? You know, does she need some district nursing input? Because not all care and residential homes are able to do everything that might be needed towards the end of life. For example, if she needed a syringe driver, is there any other equipment that we might want? Okay. And if she improves, great. But what about next time? And that's the chance to talk about, well, what if this were to happen again? What should we do? And it might be that you would do the same thing again, but at least you've had to think about things and everybody's a little bit more informed. Thank you. And just a quick recap of what people might need when they're dying. They might need their family around them, their GPs, their out-of-hours GPs, district nurses, care home staff, specialist advice, drugs, syringe drivers, DNA CPR forms, and equipment. Lots of people are already, if she's in a residential home, on an appropriate bed and an appropriate mattress, but it's worth thinking about all of that sort of stuff. Okay. We're going to talk about end-of-life care in subsequent webinars, so I won't dwell on that in any more detail at the moment. So thank you. Okay. If anybody wants to make any comments about that lady or put anything in the chat, please continue, and I will talk about another patient and again contribute to the chat for this lady as well if you want to. I'll just check the time. Okay. So as I said, these are an amalgamation of patients that I've met over the years. This is Lee. She's in her 70s. She's got pancreatic cancer and liver metastases diagnosed a few months ago. And she had a CBD as common bile duct stent placed at that time because she was jaundiced. She declined palliative chemotherapy and said she never wanted to go back to hospital. And she's actually been pretty well, living alone, independent, self-caring, walking the dog. But she's now got recurrent jaundice, which happened 2 weeks ago and is starting to get worse. Okay. So what are our initial thoughts with Lee? Do you want to put the next poll up for me, Charlotte, if that's okay? What are we going to do for her? Thank you. So lots of people want bloods and imaging. Someone's going to admit her and someone's going to set up a syringe driver, and I'm sensing that there might be interesting stuff in the chat. Please keep putting comments in if that's okay. All right, so we've got bloods, imaging and stuff in the chat. Does anyone want to tell me what's in the chat, because I can't see it? Oh, James, I can see your face. Sorry, I keep picking on you.
No, no worries. No, I've made myself visible. So there's again sort of discussing the options with her and assessing, is she acutely unwell, and is this something that can be, you know, that can be reversed? So I think that yeah, I wonder whether the last case is influenced slightly, that there's slightly more others, in terms of the first step being actually what does she want, and then working forward to actually what can we potentially do about it. So yeah, a bit of a spread, which I think is sort of reflected in the poll, isn't it?
Yeah. Thank you. Thanks, James. Okay, so you've seen her today. She's been getting increasingly jaundiced for the last couple of weeks, but she's now confused. She's having night sweats and she's not taking her tablets properly. She lives alone. She's on things like Zomorph, dexamethasone, Laxido. Okay, so I guess now what really? We're in perhaps a slightly different situation. And if you think back to the options that you just had, you might do something slightly differently, because it's tricky to see her being left at home on her own without increasing care and making some definite decisions about what direction we think things are going in, isn't it? Okay, so as we've talked about, you know, to share this decision making, talk to her if you can, but she may lack capacity in this instance. Talk to her friends, family, the teams looking after her, palliative care, and in this circumstance you might well have a conversation with secondary care as well about what might be the appropriate thing to do. So putting the situation in a longer context, I've described somebody who was functioning pretty well with her cancer up until this point, haven't I? So if there was something that we could perhaps attempt to reverse, it might be that she would regain some reasonable function, because she was functioning reasonably well. I won't go through our ethical principles again, but same really. What planning has she made? She's talked about not wanting to go back to hospital, but you know, did that apply to this specific circumstance when she's becoming increasingly jaundiced and got a stent, and it could be that her stent is blocking and she's becoming septic? And in that circumstance, it might be, if she wanted, that it would be able to, might be that it would be possible to re-stent her and reverse at least some of this in the acute setting. But her background is that she has pancreatic cancer and liver metastases, and will deteriorate probably over months for the average patient. This is something that I use all the time when people ask how long, because it's quite tricky, isn't it? But this is Robert Twycross. If people are deteriorating month by month, then prognosis might be in terms of months. Week by week, then possibly in weeks. And if someone's reached the point where they're deteriorating day by day, then prognosis is likely to be in days. Clearly, that only works if things are sort of going in a straight line. It works less well if it's something acute that's gone on. And if you think back to the graphs, it works less well for people that have got different trajectories, like the frailty and dementia, or a trajectory that's like heart failure or COPD. But this is quite useful sometimes, especially in things like progressive cancer. So management of general deterioration, we've talked about all of these things already, same sort of approach. So what about this lady? So she could well have a blocked stent and biliary sepsis. And that might be able to be reversed, or it might not. You know, she could have hepatic failure because she's got liver metastases, and she could be just, I've said just in inverted commas, but we do sometimes end up saying that sometimes in palliative care, look, this person's just dying. And we need to be managing that. So I think you would consider bloods, urgent imaging, urgent advice, and then potential admission, and you'd need to do something quite quickly if you were going to try and intervene here. In the scenario where she's pyrexial, confused and unsafe at home, then you either need to get some care in quite quickly if that were possible, or she may need to be in a different place of care, depending on whether she's also got family available. Okay, so outcomes, and you know, this, as I said, she's not a real patient, but an amalgamation of lots of patients that I have looked after over the years. So one outcome, an acute admission, treated with IV antibiotics for sepsis, biliary dilatation above the level of the stent, had an ERCP and was successfully restented, but with a comment that it was technically quite difficult. And she has improved, not back to her level of previous function, but jaundice is better, and she was able to be discharged home with a care package. So other scenarios, adamant that she didn't want to consider any interventions or further admissions. We've given some oral antibiotics a go at home because she was sort of hot, cold, shivery, and maybe a bit septic for what it's worth. Obviously, oral antibiotics are not your treatment of choice in biliary sepsis, and I think it would have been equally applicable in that circumstance to perhaps leave off the antibiotics and just manage this as end-of-life care. And so that was done at home. Family were able to stay. We've had district nursing, GP and palliative care input, hospice at home input, hospital beds, and all of the stuff that you might need if someone's dying. Or a further outcome, she's admitted acutely, stenting's unable to be done, technically not possible, continued sepsis, and died several days into admission with some family distress, as she had said that she didn't want to go back to hospital. So good outcome. What do you think? Could you pop the poll on for me, Charlotte, please? We need to try and do these quite quickly, guys, but do you think that's a good outcome? Oh, it's 50-50. So perhaps a majority of people there, only just majority of people thinking that that's a reasonable outcome. Okay, thank you. Next, good outcome, end of life care at home. What do you think? Charlotte, could you pop the poll up for me, please? Most people saying yes with that one. We need to move on, so I'm sorry if I haven't given everybody the chance to answer. Thank you. Most people saying yes there. And good outcome. What about our acute admission where she died in hospital? Most people saying no. Thank you. We need to move on a little bit. So most people are saying no to that one. I'm not sure these are black and white, and it's not fair of me to just give you yes or no answers, really. Because, you know, in our third scenario there, the acute admission where she died in hospital, well, how do we know what's going to happen? And it might be that it would have been the first scenario where she was restented and got back to a reasonable level of function. In our second scenario there, where she died at home and that all went reasonably well, let's say, that may well be a good outcome, may well have been what she wanted. But unless you talk to her, or have some sort of advanced care planning and some idea of what she might have wanted, then how do you know she wouldn't have wanted the acute admission side of things?
Joanne, I'm sorry, I know time's limited. I just wanted to make a comment that it would be interesting to do this poll, say, with surgical team or interventional radiologists. That I think we're, you know, coming at it from a palliative care angle, that the end of life care at home was seen as a better outcome than the acute one. It's more a comment than anything else, that I think it's probably a background will influence what you see as a good outcome. But I think you've highlighted the ultimate outcome isn't really down to us to decide, is it? It's up to it's kind of what would the patient have wanted. But yeah, just to pose that thought.
And what's possible, really. Okay, so I've done that slide lots of times. Confused about all our possible outcomes? Maybe it's tricky, and all we can do is plan as best we can, talk to patients and families about what they might want, be realistic about the situation that they're in. Okay, to speed things up a little bit. So Mike, 66-year-old man, small cell lung cancer, widespread metastatic disease, not for any further chemotherapy. So you've probably noticed that we probably talk more about SACT rather than chemotherapy now, so systemic anti-cancer therapy, which includes immunotherapies and some hormonal treatments as well. So it's not necessarily all about chemo anymore. So he's deteriorating weekly, spending most of his time in bed, sleeping a lot, fluctuating confusion, and he's on some opioids. So this is delirium. which is really common in our palliative care patients. And lots of you will know lots about this already. So I'm going to try and go through the next few slides quite quickly. So acute confusional state, disturbed consciousness, sort of brain failure, and has an acute and fluctuating course. Commonly worse at night, so it's sundowners. It's common in an inpatient setting, isn't it, when patients become confused and delirious in the nighttime hours, and then when the doctors are not there and the nurses are trying to manage people more with slightly less support and more on their own, and then in the morning as a doctor you stroll up and people are asleep and they look fine, and you don't quite realize how difficult the night has been. Delirium serious and associated with poor outcomes. Less so in our 66-year-olds, although dementia is not impossible in your 60s, I hate to say. Delirium versus dementia. Delirium is acute and fluctuating. Hallucinations are quite common, and people are often quite aware of it and aware and anxious, as opposed to dementia, which is more chronic and progressive. And in the later stages, people are much less aware. So how do we diagnose delirium? So there are lots of different ways of doing it and lots of tools that we can use, and I'm not going to dwell on those, but I'll let you have a look. We often sort of ask people whether they're orientated in time, place and person. We ask, whether, do you recognise this person? You would expect most people of an older generation to recognise the Queen, and I don't know how many people would recognise our erstwhile Prime Minister, but probably the majority. And you can also get people to do things like drawing a clock face, which can be quite discerning in terms of picking up people who've got cognitive impairment, but wouldn't necessarily help you to pick between dementia and delirium. And that's another tool that we commonly use in the hospice where I work, which is quite quick to use. It's whether you are alert, whether you're orientated, whether you can say the months of the year backwards. It's not that easy, give it a try. And whether you've got an acute change or a fluctuating course. So delirium, you don't have to be hyperactive and agitated and restless. You can also be withdrawn and quiet, and it's sometimes more difficult to pick that up. And patients might not really be confused. They might just be ill, can't hear you, can't see you, maybe dysphasic, maybe disorientated from their drugs, or may just be anxious. So delirium's like a threshold. It's lowered at the extremes of age. So little children who are unwell are often quite delirious. And then when you get older and more frail, your brain's probably more susceptible to something like a high temperature or an infection making you delirious. What we do to people in hospitals doesn't help them. They're in a strange place. The lights are on all the time. It's noisy. And they might not quite know, move people around from ward to ward in the middle of the night to try and increase capacity, and none of that helps really. And people might have been, used substances in the past that would make them more prone to that, and reduce poor performance status and reduce mobility, lowers our delirium threshold as well. So delirium can be precipitated by all of these things: the disease itself. You might have brain metastases, metabolic disturbances like a high calcium. It may be drug-related or treatment-related. It may be due to infection, constipation, impaction, dehydration, or may just be something that's related to your illness, but you're withdrawing from the bottle of wine that you normally have of an evening, or something along those lines. And there's a mnemonic there for delirium for some of the medical causes, which is just a different way of saying it. Opioids. This gentleman was on Longtech, wasn't he, or moderate release oxycodone. If he's been on a stable dose, then you're probably looking for a different cause, unless you've got renal failure where you'd accumulate your opioid, or it's interacting with other new drugs, or perhaps you've removed the painful stimulus. So people that have a very good response to radiotherapy, for example, for bone pain, can sometimes become a little bit opioid toxic because you've sort of removed their painful stimulus, and they don't necessarily need all that opioid anymore. Management, like everything else, identify the causes, treat reversible causes appropriately, and you might use non-drug treatment or drug treatment In delirium, you would probably concentrate more on the non-drug treatment. So treat reversible causes that you can and where appropriate. Remember that we said this is somebody with widespread metastatic disease and non-small cell lung cancer who's been deteriorating weekly. If you thought you had a chest infection, that you might consider some treatment, but you'd also be wanting to consider whether things like antibiotics or maybe even hospital admission are actually appropriate in this circumstance. Okay, you wouldn't necessarily run around getting oxygen at home for somebody with deteriorating lung cancer who was hypoxic, but on a hospital ward, you might put some oxygen on perhaps to see if it produced an improvement. You'd review medicines, you'd think about withdrawal symptoms, you'd make someone comfortable in terms of disimpaction and urinary retention, and for specific possible treatments like people with brain metastases who are confused, you might think about steroids, for example. No cause is identified in over 50% of patients with advanced cancer, so you wouldn't exhaustively look for causes, I don't think. But you would do the things that you can do for delirium, which is mainly around non-drug measures, explain to patients and families what this is, keep calm and avoid confrontation, and try and clarify any misperceptions. And the top tips there, the top tip slide there is probably quite helpful. So harness the power of the family, look at medicines, orientate your patient, find their hearing aid and their glasses and put them on, and stop crashing the bins at 4 in the morning and waking them up if they're on a hospital ward. So drug treatment, it's probably best avoided if you can, but consider if patients are really distressed, a danger to themselves or a danger to somebody else, or if there's no reversible cause found. And if they're terminally agitated, that's a slightly different scenario. And we'll talk more about that in the end of life care talk another time. So if you do consider drug treatment for delirium, it's worth bearing in mind that there's no great evidence that these work particularly well. And in some published literature, they might actually make things worse. But we'd sometimes consider medicines like haloperidol or some of the newer antipsychotic medicines sometimes, so things like olanzapine, quetiapine. And in palliative care, and perhaps if you're more in an end-of-life care scenario, we'd consider things like levomepromazine. So benzodiazepines can be useful if someone's very anxious. Apologies, my window cleaner's cleaning the windows quite loudly. Useful if there's a big anxiety component, or if they're withdrawing from something, so medicines, alcohol, something like that. And people who are used to taking benzodiazepines themselves at home who suddenly don't have them in hospital, that can precipitate delirium as well. And we might consider advice from our mental health service colleagues, especially if someone has very challenging behaviour or lots of comorbidities, or some of the dementia patients, for example. So back to Mike and the scenario that we've given. Okay, so someone's done some urgent bloods, which shows a corrected calcium of 3.3. That's high for anybody who's less used to the numbers. What do we do now? Can you run the next poll for me, please, Charlotte? So we probably only had about half the responses, but most people wanting to admit him either to hospital or hospice to treat the hypercalcemia. Is there anything that you wanted to add from the chat, James, or anybody else that's helping to monitor it for me?
I think there's a comment again along the same lines as the other ones. If depending on what he wants, what environment would he be willing to accept this treatment?
Okay. Okay. Thank you. As I said, there's not necessarily right or wrong answers. It all depends on your scenario. I suppose for this gentleman, I have described somebody with widespread disease, no further use active treatment planned, deteriorating weekly, spending most of his time in bed, sleeping a lot. So I'm describing a scenario where he may well be towards the end of his life and time could be quite short here. And I guess I've deliberately described that sort of scenario. Yes, he has got hypercalcemia, but you have to wonder how much of this is actually reversible, because we're perhaps describing someone who's dying. And yeah, it might be somebody that you wouldn't necessarily always take the bloods in the first place. You'd perhaps be wanting to have your what do we do here in the advanced care planning conversations, you know, maybe even before considering whether we would take blood from him or not.
I think I was gonna just make a comment on that, Joe, exactly to that effect on actually, if we're going to do the bloods, then we need to know what we're going to do with them. And the scenario I usually give to patients and families is, if you know, if this goes through, say, to the out of hours GPs for some reason, or someone who doesn't know you at all, and they see a blood result that they're worried about, then what do you want them to do with it? And actually, if the answer is actually I don't want to go in anywhere, I don't want to be to have any specific treatment for it, then you can have a suspicion of it and treat and do what you can at home, but you wouldn't necessarily do them, because you're going to leave someone at the sort of at risk of a sort of almost a panic admission if somebody's potassium's high or calcium's high.
Yeah. Thank you, James. So I suppose, yeah, it's we might decide that this gentleman's dying. We might or might not want to take bloods, or even if we might not want to act on the results. It all depends on the situation. Okay, it's not necessarily a right answer for these things. Okay, we've got a few minutes left, so I'm just going to quickly go through our last patient, Bert, 92. Lots of comorbidities, including heart failure, ischemic heart disease, diabetes, Parkinson's. Again, gradually deteriorated over the last year. He's at home. He doesn't go out and has had some falls. He lives with his elderly wife, and his family are close by. Typical scenario here for those of us who work in the community, I think. When you visit him at home, there's medicines all over the house, out of their packaging, unlabeled, and that's his comment on the whole situation. I'm sick of taking these tablets. They're making me sick. I'm going to stop them all. Just leave me alone. So you might be a GP, a district nurse, one of the palliative care team members, or perhaps somebody who's working with hospice at home teams. Okay. These are his medicines. I've put a Claudine to WCP, which is Welsh Clinical Portal, because actually what's GP records or Welsh Clinical Portal or your green prescription slips say that you're taking doesn't always bear much resemblance to reality, but this is what Bert is supposed to be on. Also, people don't give you a nice succinct list of all their comorbidities either, do they? You sometimes have to look at their medicines and try to guess, or furosemide, he might have heart failure. Mazepar there, maybe he's presumably got Parkinson's disease. So he's on all of these things. If you added all of those tablets up, it's a lot. And there's a picture there of people who are elderly, sort of made of tablets, really, and that is how some people feel. So I'm just going to run the last poll, if that's okay, Charlotte. What are we going to do for Bert? I don't know if you can read all of the scenarios there. So it's ask his family, wife or carers to make sure he takes all his medicines, set up a syringe driver, especially for his analgesics, stop his oral medicines because he's not taking them properly anyway, talk to him, talk to the clinical teams, rationalise, deprescribe, and try to work out the best thing to do for each individual tablet, or tell him to stop taking his cyclizine because he might stop feeling sick then, or other, put it in the chat. There probably was a right answer for this one, wasn't there? So thank you, all of you who have said yeah, talk to him, talk to his family, talk to the clinical teams that are involved, and try to rationalise and potentially deprescribe some of his medicines, and talk to him about what's important to him and what he might want out of this scenario. Okay, is there anything in the chat that we need to stop for, guys?
Just an interesting point from Emma saying that about a medication review, but also look for other reasons that he's not taking them. You know, is he depressed? Is there an underlying cause for him not taking them other than just increasing frailty, which I think is an interesting point.
Thank you. So share the decision making. You might want to involve, you know, people like secondary care in this as well, especially if he's not taking things like his Parkinson's medicines or his diabetic medicines or his heart failure stuff. And involve all of those who perhaps involved in his care. Okay, so very quickly, principles of deprescribing in palliative care. Would you be surprised if he were to die within the next 6 or 12 months? Well, he's in his 90s, has got lots of comorbidities, and we've talked about deteriorating function. So I think perhaps we probably wouldn't be surprised. And what would happen if you stopped each individual medicine, and what would happen if he continued to take it? So we'd often divide the medicines into things like, is it for short-term disease or symptom control? So you can see that if he's got heart failure, stopping his diuretics probably wouldn't be particularly helpful, and you might want to continue them. Things like the bisoprolol to control the rate of his AF might be important. And the Oromorph, not even sure what it's for. Is it for breathlessness due to heart failure? Is it for his severe osteoarthritis? Don't know. But you'd often want to continue medicines like that. You know, shared decision making with him, obviously, but you might want to continue those, and you might need to consider alternative routes. You'd certainly have the Parkinson's medicines up in that list as well, which would be important to not suddenly stop. Are the medicines more for longer term prevention of possible adverse events, statins, and possibly the warfarin if it's AF? You know, he's somebody who is probably taking it haphazardly and falling, and I think that would be something that you might really want to consider whether it was the best thing to do, risks benefit wise, to continue. And then things like diabetic medicines, they've got a role in short-term control and longer-term prevention of complications. We're perhaps less worried you know, about the longer-term complications of diabetes in this gentleman, but we wouldn't want him to have acutely high blood sugars and have a diabetic crisis from that, and we wouldn't want him to have hypos either. So I'm not going to go through this in any great detail, but you know, it's about looking at each tablet individually, talking to him, talking about what they might or might not do, and getting advice from other people if needed. So some of them there, like the Madapar for his Parkinson's, you know, you might want to chat to the specialists in Parkinson's there about alternatives, and we can sometimes use some patch formulations for people who are unable to take their Parkinson's meds. And cyclizine there, it depends on the cause of his nausea and other comorbidities. Cyclizine is not great for heart failure, but then with patients with Parkinson's disease, we're a little bit limited in our anti-sickness medicines as well. So one slide on nausea and vomiting that we're not going to cover, but in any great detail. But gastric stasis or stomach not emptying properly, we might use medicines like metoclopramide or domperidone. People who are obstructed or have motion sickness type sickness or raised intracranial pressure, then cyclizine is a reasonable drug. And for people, if we think the cause of the nausea and vomiting is medicines or biochemical stuff like raised calcium, for example, or renal impairment, then we might consider things like haloperidol. And I've just put a slide up there for the receptor affinity. Just to remember, patients with Parkinson's have not enough dopamine in their system. So if you give them medicines that block dopamine, it can make their Parkinson's symptoms worse. And therefore, for people like Bert, you'd want to avoid things like haloperidol and metoclopramide for nausea, and you might be using things like domperidone or cyclizine. But I'm not going to go into that in any great detail because we're coming to the end of the talk. So thank you very much for joining us. There's the QR code. to just fill in your evaluation. That would be great, really helpful if you can do that for us. And very much hope that you will also join us next week. Thank you very much. Can I go back to one of my colleagues to see if there's questions or comments that we need to pick up on? And I'll leave the evaluation and the QR code up there.
In the chat, I think there isn't anything else specific that's sort of come up there. I think it's just it's an interesting. I mean, it's probably one of the most challenging times looking after somebody is that period of deterioration, isn't it? Because prior to that, things are going okay. When it's clearly end of life care, then usually it's more obvious, isn't it? It's this what do you do and when, and it being very individual, that actually makes this probably one of the trickiest times of someone's someone's sort of healthcare journey. So yeah, I think it's good just to discuss some of the ways to approach it. But I think, as you've alluded to, Joe, I think if you'd have a lot of different people doing different things, and if you had two people with the same case, they may do something different, but it's not necessarily that either would be wrong. It's just a different approach, isn't it?
Thank you. So thank you so much for everybody who has joined us. Again, please fill in your evaluations. And that's us for the sort of formal hour webinar part of this. We are going to stay on for the next half hour, if that's okay, for anybody that wants to talk about sort of, particular patients or particular things that they find difficult. And we might be able to have a bit more of a panel discussion on some of these things with my colleagues.